I want to thank Bobby and Peter for joining us here. We're thrilled to have a discussion on what is typically, we're going to try to demystify what is typically a very, very complicated topic. But I want to say to everybody who's here, how many of you are coming to the Fed for the first time? And how many of you have been here before? All right, so that's great. So when we first started asking that question about a year and a half ago, the mix was shifted, and we're thrilled to have you all here. Many of you are people that we consult with, get your advice from, you fill out our surveys. We need your engagement, and we need the public's engagement for us to understand economic conditions and to do the job we do. So for all of you here tonight, thank you for being here, and thank you for all you do to help us. And with that, I'm going to start with Peter and Bobby and ask one question to start. What's the biggest misconception about the healthcare system? What's the biggest misunderstanding that people have?
Well, first, let me just say I'm delighted to be here. Also, I wanted to note my wife grew up in Houston. My father-in-law is here, and I'm delighted to be kind of in my second hometown. So thank you for having me. I'm going to point to two misconceptions. The first is that most Americans get their health care through their employer, and there is a misperception that we all then don't pay for the bulk of how much it costs because your employer is paying for it. But all of the evidence and economic theory suggests ultimately we all pay through reduced take-home pay, that if your company is paying more for health care, they're going to wind up paying less in wages. And so there's sort of a little bit of hiding the ball because it seems like people hear it's inefficient, but maybe we don't care that much because we're not directly paying for it. The fact of the matter is we're all paying for it directly. Secondly, we have this perception that there's sort of one way in which healthcare is delivered. If you have this illness, you should have this happen to you through the healthcare system. And the fact of the matter is healthcare is practiced in dramatically different ways across different parts of the country, across different hospitals within the same part of the country, across different doctors within the same hospital. So everything from, you know, the probability as a pregnant mom that you have a C-section versus a natural birth dramatically varies across the country. The cost of care varies substantially, even across our top medical centers, with some places, you know, cost per beneficiary being 2 or 3 times what it is at other places. And it led the Princeton economist Uwe Reinhardt to say, how can the best medical care in the world, which at our leading places we do have, how can the best medical care in the world cost twice as much as the best medical care in the world? So a lot of variation in how healthcare is practiced, and we tend to think of it as being a single thing, but it's not.
Okay.
Yeah, well, just to follow on those, amplify on those answers, which, of course, Peter is the expert here. I'm the fill-in, but Rob, thank you for inviting me to participate. I think to follow on, big misconception, you ask us one, but I'll give you a McKinsey 3 answer, right? Yeah, I'll give you 3 points. One is that we're getting a great deal. We're not getting a very good deal. I mean, just listening to the opening remarks, we're not getting a good return on investment. So that would be one, and we can expand on that. I do agree, though, at the great centers, you get the best care in the world at MD Anderson, hands down, no question about it. The second is that that the system was designed for patients. The system's not designed for patients. It was designed for, you know, if you look at any business, you know, if we ran healthcare really like a business, customer service is not the top of people's minds. You know, particularly with people like heart surgeons, of course. The patients wait for us. You know, we're not there to serve them. They wait for us. They should be honored that we're there to treat them, right? And the system is just not designed to, in my opinion, serve the customer.
Who's it designed to serve?
It's designed to serve the medical economic complex, and it's really designed for the providers, right? How many times would you go to a place where you have to wait for 2 hours in a waiting room and have to make 10 calls and all the things, right? I can be a little bit provocative because hopefully we'll stir some discussion. And the final thing, and Peter alluded to this too, as we were discussing his harrowing landing right in the perfect corridor between thunderstorms together. So thank you for making the trip down here. It's assumed, and he alluded to this, it's assumed that quality is the same everywhere. We know that that is absolutely not the case. As we try to reach the triple point of the highest quality of care at the lowest cost with the best customer service, we're not really hitting it on all those different parameters. But assuming that you're going to get the same quality of care regardless, it's like getting on an airplane. We don't choose which airline we're going to fly on based on their crash record or their safety record, right? We assume that the quality is going to be the same. And in healthcare, I think there are false assumptions that the quality is going to be the same no matter where you go.
And can I stay with that? So what drives the variation in quality? What's driving it? Is the quality of the provider? What drives it?
I think it's a multitude of factors. One, it's the ability of the providers, but I would say more importantly, it's the culture and the team. You can be the greatest heart surgeon in the world, but if you don't have great anesthesiologists and nurses and perfusionists and people to make the team work. So I think the really good places not only have great teams and they focus on quality, but they also, not surprisingly, are better on cost.
So there are a couple of dimensions to this. One is just, even at the same institution, timing matters. So the evidence strongly suggests, just note to self, you don't want to be admitted to a hospital, at 6 p.m. on a Friday night, because all of the indicators suggest that weekend quality is significantly worse than weekday quality, and it kind of speaks to the question of for whom this system is designed. But then there's also, on average, there have been some clever studies that looked at, what we'd really like to do is randomly assign people to different hospitals so you could see what, and that's not going to happen. So you have to kind of come as close as you can. And there have been two different approaches that are clever to try to do that. One is, it's long been known that people, Medicare, for example, spends a lot more and does not get higher quality in some areas than others, but there's always been this question of, well, are the people just in some way you can't measure sicker in Florida than they are in Minnesota? And so there have been recently some studies that look at people who move from one area of the country to another, and what they found is that if you move from Minnesota to Florida, spending on you jumps dramatically within a short period of time of the move, with no corresponding improvement in quality. And if you move from Florida to Minnesota, the opposite thing happens. So that's strongly suggestive that it's sort of, this is how we practice medicine here, not more money leads to better quality. That's the first thing. Second thing is, there have been studies that look at ambulance referral regions within big cities. I don't know how it works here in Houston, but in many large cities.
There's more ambulances in Houston than any other city in the country.
Okay, right. And typically, in most big cities, you'll carve up the geography into different ambulance companies will cover different parts of the city. And what that then opens up is, if I'm living across the street from you, but the referral region goes down the middle of the street, no one knows where these, I don't even know in New York where we live, I don't know what ambulance company covers us. No one knows where these things are. It's almost randomly assignment, therefore, if one ambulance company will pick you up, another one will pick me up. And the studies that have done that have found the following things. It's really interesting. One, a high-cost emergency room looks like it actually pays off. The mortality rates and other things from higher-cost emergency rooms, that's a good thing. Yeah. But, and here's the big but, as you follow that patient through these different hospital systems, first you find dramatic differences in how much is spent on them. And again, coming back to kind of, if there were one way of practicing medicine and this was sort of random assignment, that shouldn't happen. Secondly, as soon as you leave the emergency room, everything else that happens looks like it's got a negative return on dollars spent, especially, I hate to say it, but especially after you leave the hospital in the post-acute space, skilled nursing facilities in particular, but other forms of post-acute care, looks like they have the deepest negative return on additional dollars if you look at any measures of quality. And so what you get from that combination is the old finding from Dartmouth and the Wenberg folks of additional money on average doesn't look like it produces better results, flat of the curve kind of thing. But that's in part because there are these different moving pieces, and that's the difficulty in trying to get to, well, what do you do about it? Because you don't want to just cut spending indiscriminately. That will take out the good parts also. You need to find the places that have very low value added or negative value added and try to improve the situation there.
So back in 08, 09, you famously talked about the bending the cost curve, right? And in fact, I think you advised President Obama, we've got to bend the cost curve if we're going to deal with the budget situation in this country. And so I guess my question is, explain to the group, what does bending the cost curve mean? And now, 8 or 9 years later, have we bent the cost curve? And how have we done?
Okay, so bending the cost curve really was about, if you looked at projections of the federal government fiscal balance, they look like this. The debt to GDP, exploded in a hockey stick. And that was being driven mostly by Medicare and Medicaid looking like this. So bending the curve would be simply kind of trying to turn a hockey stick into something else that didn't have quite that trajectory. And I'd say this is an area in which there's actually been surprisingly more positive news, despite everything you read about premiums on the exchanges, which I'll come back to in a second, than you would have imagined. So I would put forward that if I had addressed a group like this in January 2010 and said, I think that that is, take out inflation, so inflation-adjusted spending per Medicare beneficiary will decline for 7 years in a row. Everyone would have laughed at me because that would have been ridiculous. That's actually what's happened. And by the way, it's continued through this year. So Medicare spending this year is up less than 4% nominal. You take out inflation, you take out beneficiary growth, that means real per person spending in Medicare is continuing to decline. Now, we can debate why that is and how much of that is still the lingering aftermath of the financial crisis, and the evidence suggests basically none. But what's causing that? But it's a fairly substantial change, and it's caused the Congressional Budget Office, which I used to run, but I can assure you does not update its forecasts rapidly in response to incoming information, to knock down the share of GDP that is projected to go to Medicare and Medicaid by almost 1% of GDP in 2022, and then to carry that out over time. So the debt trajectory that the United States is on is still not pretty, but it's a lot better than were it not for this deceleration. And we should talk for a second about what might be causing it. But I also need to turn to the premiums on the exchanges because that's what's gotten so much attention. And what people need to remember is we're talking about 10 million people on the exchanges. For the vast majority of Americans, the experience on the exchanges is not what's happening to them. So you should look at employer-sponsored insurance premiums on Medicare. That's a far larger population. And yes, there have been issues with premiums, which I hope we'll turn to also, and exchange stability and all of that. But all of the attention, all of the media focus on the exchanges is missing this bigger story, which is there are, 4 times as many Americans on Medicare, and the Medicare spending growth has slowed down substantially.
So take a stab. So why? Take a stab at why that might be happening.
All right. So everything I've said so far, I can back up with facts, and what I'm about to say, I just want to be clear. I'm going out over my ski tips because no one really knows. So I just want to say that. But we can rule out some potential explanations. It's not mostly price. So in the 1990s, there was also a slowdown in Medicare spending, mostly because we cut reimbursement rates to providers. There's a little bit of that going on, but mostly this is utilization. So how much we spend per 80-year-old there's been a change in the growth rate of that. So then the question becomes why? And one reason is there have been some changes that create incentives for higher quality and lower spending. So I'll give you an example. Historically, we had 20% or so of people who were discharged from a hospital on Medicare readmitted within 30 days. The 30-day readmission rate's 20%. There's now a penalty against high readmission rates, and that rate has come down to, let's call it 16%, still way too high, some progress. But if you add up all the things like that and put them all together, they explain maybe a quarter of the decline in spending. So it raises this big mega question, what is going on here? And here's where it's my belief that a lot of what's happening in hospitals and physician groups is anticipating that the way that payments have worked in the past is not going to be the way payments are going to work in the future. So historically, we have paid basically piecemeal. So if you do more stuff, you get paid more, fee for service. Not surprisingly, if you pay for quantity, you get lots of quantity. We're in this process of a painful, slow, confusing, ambiguous evolution away from that towards paying for value. It's hard. There's 2 steps forward, 1 step back. There are multiple different ways of doing this. But I think there's a general perception in the marketplace that we are moving away from fee-for-service and towards this other payment system. And to get ready for that, you need to start doing lots of things internally in your hospital to change the way healthcare is practiced. So that is my leading hypothesis. And the danger in that is, since it's based in no small part on expectation, if we don't fulfill those expectations, a lot of this stuff could get undone.
Yeah, I think he's spot on about that. And there's a guy who came to, so we have Michael Porter and Bob Kaplan come down, other Bob Kaplan, come down.
I know him well. No, he's the real one.
Yeah, no, it's not true. They come down to give their sort of 2-day version of their value-based health conference here in Houston every year. And we've talked a lot in the community and the people who've had the privilege of attending that about these issues. And one of the guys that we had this past year attend is a guy named Jeff Rich, who is a Stanford-trained cardiothoracic surgeon who unexplainedly took a year off of his private practice to serve as the head of CMS. And he wrote a lot of these things into place that are going to, for instance, sternal wound infections, you take the risk if it's a should never happen thing. And just parenthetically, to go back and give you should be able to take some things away from this discussion tonight. And so one thing is, Peter's right. If you have to have an operation, make sure it's like the airlines and you're the first flight out, be the first case in the morning. Because the infection rate and other bad things that happen get worse as the day goes on.
Wow.
So coming back to that, so Jeff Rich was important in writing some of these things into law. And I think Peter's absolutely right. Everybody's focused now on medication consolidation, reconciliation, not doing everything they can to prevent readmissions, doing everything they can to prevent sacral decubiti or bed sores, surgical site infections, on and on and on. So I think that's exactly right.
So by the way, for those who don't know, Michael Porter and Robert Kaplan, the bulk of their work, which I worked on some with them when I was at Harvard, is how to change the reimbursement process in this country and the payment system for outcomes rather than based on procedures. And they're actually struggling to get take-up, but this is what their mission is, and they're working on it. So let me ask one other question. And Mark mentioned it in the introduction. There is a difference what we pay per capita in this country versus every other country. And I mean, the gap is like 5–10% of GDP. My assumption has always been the difference between the United States and every other country is we've got an insurance industry here and other countries don't. Is that the difference why we spend so much? Why do we spend so much versus other countries?
And let me be careful here because there are different ways of looking at variation. So the primary reason we spend more in the United States than in Europe or Canada has to do with how much we pay per unit of healthcare. In other words, how much we're paying for. It's not that we're doing more MRIs, even though we have the impression that we are. It's how much we pay per MRI scan.
Including insurance premiums.
Including the insurance premium. And so that's one, we have a profit load and an administrative load and what have you.
Yeah.
But the bulk of it has to do with price. If you look across the United States within Medicare, by contrast, the prices are basically kind of sort of the same. And most of the variation in Medicare, which is also huge, has to do with utilization, how much we're doing per patient at some places versus the others. And then finally, if you look across the United States within the employer-sponsored world, that's mostly how much each employer through their insurance company is paying providers. So there are different dimensions here, but bottom line, relative to other countries, it's mostly price.
Mostly price. And there's been a lot made of the fact we pay a lot more for drugs here.
Yep.
Is that the bulk of the change in
So
prices across the board?
Drugs, depending on how you count, are somewhere between 10 and maybe at the upper end 15 to 20%, but they're the minority of healthcare costs.
So it's for every other service we're paying more.
Everything, all in. Right.
And I would agree. I'm not going to disagree with Peter at any point in the program, so I'm not going to.
You should have told me that at the beginning.
Yeah, well, but I would also say, I mean, if you're a medical device company or you're a drug company and you want to get your product to market, you want to get it into the U.S. because exactly right. You're gonna get paid more, and then you can fund all the $1 billion it took to get the drug developed into market.
And the reason you're going to get paid more here is because there's a private sector and there's a profit motive? That's why?
I think so. Yeah.
Where in other countries, it's cost plus.
Well, they dictate the price effectively. So other countries will just say, we are not paying more than X for this drug.
They're price controls.
Right.
And it is true. I mean, this is why for patented drugs, so for the new drugs, a lot of the press attention has been about these big price increases for drugs that are actually not patented. They're off patent, and so it's a different issue. But for the big, the big pharma where there's innovation going on and patents, the trade-off is really hard because it is simultaneously true that we Americans are cross-subsidizing innovation in pharmaceuticals for the entire world.
Right.
Yes.
We're doing that.
Right.
And secondly, that if other countries aren't willing to pay more because they've got their systems and that's that, how is the innovation going, what are the incentives going to be if we just cut back? That's part of the dilemma here on pharmaceuticals, which is we are cross-subsidizing the rest of the world, but no one really knows how to get out of that box without turning off the innovation that is important.
All right.
So could I just follow on to that?
Yeah, I want to get some other things.
Yeah, I won't disagree, but I'll just try to amplify what Peter's saying here. So look at 3 events. One is that everybody in the room, the U.S. government decided how much your life was worth in, I think, 1973, something like that, when they decided we will pay $70,000 a year at that time to dialyze you to keep you alive. Okay, that's one point. Second is that there was all the outcry about, only wealthy people can afford the cocktail for HIV, and we need to democratize that. The third one is happening right now, and that's hepatitis C. And the drug costs a tremendous amount of money, but it can, quote, cure you. And so you're looking, and I'd love to hear Peter's analysis on this, but you're looking at one point in time, how much that drug costs compared to an outcome. You're not taking into consideration that patient over the lifetime of developing cirrhosis and getting a liver transplant and fee-for-service and costing more and more money. And who bears that cost? Is it the insurance company now? If you because people move around in different insurance plans. But I'd love to interject that.
I know you want to move on. But look, the hepatitis C, so Sovaldi and the other drugs that were developed to deal with this, it's actually a really bad example if you worry about high drug prices, because in present value, if you're preventing 10 or 15 years down the road a much higher set of costs, it's worth it, clear in a way. The real problem is for a new oncology drug or a new that's not particularly innovative. There are some that are quite innovative, but where there's a very marginal improvement.
You get 6 months more
at most, and it's an outrageous cost. That's a completely different thing, and yet a lot of the pricing kind of blowback has been about the Hep C drugs, where I think it's sort of misplaced.
Yes.
All right. So let me ask you a couple of proposals that have been made recently, and I want to talk about the impact. In the recent discussion of repealing the Affordable Care Act and replacing it, there was a proposal about block granting Medicaid on the view that it would give money to the states and then say to the states, you manage your health care. And I'll start with Bobby on this. What would have been the impact? What would be the impact of block granting Medicaid to the states?
Yeah, well, Peter's got a much better explanation for this in terms of the economics than I do. But I would say, just in general, the concern, and I'll use Texas as an example, as hard as we all tried, this was not going to be a Medicaid expansion state. And the issue was Texas politicians wanted block grants because they wanted to have control. The problem that I think that, block grants are sort of an illusion in a way, in that, will the federal government be able to continue to provide that level of support once you get people into the Medicaid programs? The state is concerned that they're going to have to take over more and more, and that's the problem with Affordable Care Act and taking Medicaid expansion. It's 100% paid for by the federal government, then it goes to 10%. The big concern was that the federal government's not going to have the money to provide that
just so
support.
people are clear, under the Affordable Care Act, there was a grant on Medicaid to the state, but it was per participant.
Correct.
And now what's being discussed is just a block. You deal with the number of participants, we'll just give you a block.
Well, sort of. I mean,
Why don't you explain that?
So the way the Medicaid program works today, the federal government has let's call it 60 to 70% share of the cost, and the states will have something like a third. For the expansion part, for the part that sort of the Affordable Care Act added on top of it, the federal share was higher, initially 100, and then it came down a little bit, and the state share was lower. But what a block grant does is it then shifts all of that risk, but also presumably more flexibility, to the states. So the federal government says, instead of sharing 2/3, 1/3, we're going to give you a fixed amount, and then it's up to you. Now, a couple things about that.
And by the way, the basis on which you would decide how much you get is based on what you're getting now?
Oh, it's a big question.
Okay. All right, so I don't want to get to... But
just really quickly on that, I mean,
Yeah,
if you do
please.
it based on how much you're getting now, then the argument is you're rewarding the states that were inefficient and had high costs.
So there's a debate about that.
Huge debate about
Okay, fair enough. So keep going.
So the issue with the block grant is two things. One is the way that most of these federal proposals work, they would index the block grant, that is how much it increases each year, to a rate that's much slower than healthcare costs. And so over time, you're sort of assuming some budget savings without any clarity about where that would come from. And the really Machiavellian way of doing this is, in order to induce governors to think this is a great idea, you bump up the block grant for 2 or 3 or 4 years, and then you kind of flatline it. So there's more money on the table from the federal government to start with, and then the fact that your successor is going to face a growing problem, not your problem.
So let me get into, the CBO then did a study of the impact of this, and it concluded many millions more people would ultimately be uninsured or uncovered if this was done.
Because you have to, the great
Why is
promise
that?
here is, well, there are two things. One is, don't forget, a lot of what happens on Medicaid is if you hit a bad time, the state hits a bad time or the country hits a bad time, and more people, lose income and qualify for Medicaid, the Medicaid rules go up. So under a block grant, if that happened, the state is...
They take the risk.
They take the risk. Or Sovaldi comes along, or a Hep C drug comes along, and that wasn't built into the block grant, it's on them. So there's sort of a cyclical or unexpected...
So it's shifting the risk to the states.
Shifting the risk to the states. Now, the argument is you give them more flexibility, and there's enough inefficiency in the Medicaid program that you can kind of make it work, but no one's really, sort of laid out exactly how that would play out.
Okay.
And there is one category here that I think is of particular note, which is the people who are eligible for both Medicare and Medicaid. They're called dual eligibles. Mm-hmm. The care that they get is typically very disjointed because part of it's on Medicare, part of it's on Medicaid. It's sort of like all like that. And if you wanted to look for one area where there's dramatic improvement by kind of cleaning things up and simplifying and unifying it, it would be for the dual eligibles. That doesn't require an overall block grant, but it does require taking this particularly costly population and figuring out a better way of doing things for them, because right now it's very confusing, federal, state, 2 different programs. It's a big mess.
All right, so let me give you another one. There has been a lot of discussion in the Affordable Care Act, one of the elements, which was very controversial, was the individual mandate. The idea that the government would try to encourage healthy people to get insurance to improve the risk pool, which would lower costs. And it unfortunately, for many reasons, healthy people didn't sign up at the rate. You can correct this, at the rate that people had hoped. Now the discussion is, let's get rid of the individual mandate. What is the impact of relaxing or getting rid of the individual mandate?
Yeah, well, I think, a lot of people there was a penalty with it. It's cheaper to just pay the penalty than to provide it for small business owners. And I think that's probably where at least the current administration and leadership in Congress is heading. But of course, the mandate in just expansion or repeal and replace, I love that the joke is they want to get rid of Obamacare and replace it with the Affordable Care Act, right? So the issue, of course, is how many people are going to lose coverage. And that's a fundamental issue. All the things that are talked about, but there's still, once you give a program to a group of people and take it away, that is not going to work very well, just politically speaking.
Let me just spend a second on the context because I think it's important. So every plan to expand coverage that relies on private insurance uses what's called community rating. That is, your premium, how much you pay is not going to depend on how sick you are. And by the way, the thought that you cover pre-existing conditions, that's not actually the heart of the matter, because if your pre-existing condition is covered, but your insurance costs you $100,000, that doesn't do you very much good. It's got to be that your health insurance premium doesn't depend on your individual health status. It's called community rating as opposed to medical underwriting. And once you accept that premise, then you've got to make sure that people are going to participate before they get sick, because the obvious thing to do is wait until you get sick, then buy in at that community rating, and you've gamed the system. So you've got to get people in the system, either through a mandate or through some other kind of club to try to encourage them to participate early on. And then once you do that, for many low and moderate income families, they're not going to be able to afford the premiums that are entailed, and so you need some form of subsidies. So the joke about replacing Obamacare with the Affordable Care Act, I mean, partly it's just once you accept community rating, everything, the basic structure kind of follows, and you can call things different names or what have you, but that basic structure is what's required. So I'm open to, it's totally. There's nothing written in stone about a mandate, but you do need, in that second piece, you need some way of getting people involved so that they're just not gaming the system and waiting to the last minute, because then the whole thing implodes.
So let's ask one last question that I want to turn to the audience. If you had to take one specific action or step that you would like to see done to improve, given we're sort of now, we're in limbo at the moment, one action that you'd like to see done to improve the healthcare system, what would it be? If you could actually make something happen and have it passed by some miracle through Congress.
Coverage for everyone.
Okay, explain why.
Well, because, look, we're in the open, I come back to the opening remarks, we're getting a raw deal here. We're not getting a good return on investment for all the reasons that Peter has outlined. But it's almost an embarrassment. We're really the only developed country in the world where we're still having this debate. And
how would you have it paid for?
Well, that's the question. I don't know that. Higher taxes, of course.
So you could say two ways. We're going to have an individual mandate, and we're going to enforce it.
Right.
And we're going to have subsidies with this 3.8% surcharge. That'll help with the subsidies. And I guess what's left, we'll have the federal government take it.
Right, or as we talked about when we were pre-gaming, is we've got a great system, as the president has said a couple of times. It's called Medicare. Let's just put everybody on Medicare. Well, that's a great idea, but how do we pay for it? And then Peter has the answer for that.
So here's what if I had one thing to do at this point, it would move us more quickly away from that fee-for-service payment structure.
Right, to outcomes.
As rapidly as possible. Mm-hmm. And we've made some progress, but it's not been fast enough. And so if I had to, snap my fingers, that's the one thing I would do. And there are lots of other really important things, but you said one, so I'll stick to it.
Okay. And you agree, the thing I've been wrestling with, the dilemma is, if you could get a good risk pool, that would help potentially lower costs, yes?
Yeah, although,
You're
look,
more worried about the way
so
services are paid for.
Yeah, let me, I mean, there's a lot of stuff about trying to make the premiums work better. And
Right.
we can talk a lot about the age bands and the risk pool and lots of stuff. But fundamentally, premiums depend on the cost of care in the local area.
Okay.
Really what it comes down to is that's what drives it. So you can do a lot of stuff around, to try to make the insurance markets work better, and we should.
Yeah.
But you also, the more important medium or long-term thing is keep your eye on the underlying cost of care, because that's what's going to drive premiums.
So let's take this. To get from here to there, one, you could change the way payers reimburse. Would doctors and providers need to be retrained to operate in this system, or would you think they would be able to handle this?
Well, it's sort of happening. I mean, if you look, the Dell Medical School, for example, I mean, it has a completely different curriculum, a different emphasis. A lot, even at some of our other medical schools, there's been change. I mean, I think there is partly a generational thing. There's no doubt about that.
But we're moving this way.
But we're moving this way, and here's the way I would say it. Let's come back to that readmission. So you're leave the hospital. Why did it take so long? This is not rocket science. If you put a social worker on someone, make sure they show up for their doctor's appointments, take their drugs, you can cut readmission rates by 50%. So why was that not happening before? And the answer was we were paying hospitals every time someone was readmitted.
Right.
That's right.
So
incentives.
Or
reverse
another way of putting
incentives.
It's asking a lot of hospitals and doctors. I mean, they'll claim they're doing the right thing, but it's asking a lot of them to do the right thing at direct financial harm to themselves. So if you change that, and if you sort of flip it on its head and give them every incentive to do the right thing by reducing hospital-acquired infections, by reducing readmission rates,
One last
they
question.
will. I
And
think
then
they
who
will.
has the power to make this? Let's say we all agree, great idea. How do we change? How do we do
Here's
it?
the thing. So you can rely on private insurance companies to do this. The problem is that they're usually too small, each individual one. So I come back to, in my opinion, the only entity that's big enough on a national basis to really shove the system in this direction is Medicare.
Okay.
Yeah, could I just add one
Please,
follow on
go
that?
ahead, please.
If you're just to hammer the point home about value-based care, if you're a heart surgeon, you get paid no matter how many times how much the death rate you have, right? You're not getting paid because you're really good at what you do. Now, one of the things of gaming the system, and the cynic would argue that this really is a roundabout way or a Machiavellian way to introduce rationing into the system, right? Because obviously at Stanford we were sort of the court of last resort for really sick patients, and every time you ask someone, you've got a 80% chance of surviving this operation, but if you don't get the operation, you got 100% of dying within the next year. Guess what they do? They will take the operation every time. Yeah. But then, you're going to get penalized because you're taking on those high-risk patients. So people have started to back away and realize that, I thought the number would come out here, but it's probably 80% of healthcare is spent in the last year of one's life. And so I think that there have been a lot of incentives to reward value and reward outcomes, and a lot of the potential utilization in the Medicare population. I agree pricing is the big point, but there is going to be discussions about, hey, you're 90 years old, you need a triple bypass. Do you really want to do that to help you live another 2 years?
Okay. Let's take questions. But please go to the mic if you could, just so everybody can hear you. Thanks. Yes, this gentleman in the middle.
Who knows nothing about healthcare.
Yeah. I was intimidated to be up here because he knows more than...
Okay, so one for Peter and one for Bobby. So Peter, should CMS negotiate pricing for drugs?
Yeah.
And why aren't they?
Yeah.
A little bit about that history. And Bobby, talked a lot about the unevenness of care. does AI and related technologies hold promise for leveling the evidence-based care that we see throughout the healthcare system?
All right, so I'll tackle mine first. You'll have heard a lot about pharma drug pricing, and the leading proposal to tackle drug pricing has to do with letting the Secretary of Health and Human Services negotiate drug prices as part of Part D of Medicare. There's currently a prohibition against the Secretary doing that. So this is really interesting to me because when I was the director of the Congressional Budget Office, and people don't really pay attention until they do, as we saw during the last, what just happened in Congress. We were asked, dear CBO, please tell us what allowing the Secretary to negotiate drug prices would do. And no one seems to have paid any attention to the fact that we said quite clearly, and I remember this because I signed the letter, basically nothing. And it may sound counterintuitive, but the reason that you have traction as a negotiator in drugs is either you're going to bring a lot of lives with you. You have a formulary and you say, you give me a good price and you're going to get 5 million people or whatever. And none of the proposals actually create a CMS or HHS formulary. They just have the Secretary kind of floating without the lives behind him or her. And secondly, the second way to do it is you just stipulate the price. Like Medicaid has a fixed rebate, or in other countries that we talk, you can just say, here's the price. Well, the proposals basically don't do that either. So it would basically be the Secretary walking into the CEO of a major pharma firm and saying, hi, I'm the Secretary, could you please reduce your price? And the CEO saying, thank you so much for visiting. So in isolated cases, there's always the bully pulpit effect of the threat of other action, but you can do that now. So we really didn't see what the proposals as written would do.
Yeah, so Ron's question about artificial intelligence and machine learning. Obviously, he and his wife, Linda Chen, have been real leaders and visionaries in this area. I would not necessarily want to be a pathologist or a radiologist at this point because I think there are algorithms being developed by all the major diagnostic companies, whether it's GE or Siemens or Philips, to take a chest film or a CT scan and have that image be read by an algorithm that could be better than, you got 12 different radiologists reading, you get that variability. So getting back to the Six Sigma principle of we want to try to reduce the variability. And I think that, for instance, if I've got a mole on my hand and I take a picture of it and I say, Siri, should I get this biopsied? Well, Siri sees enough of those, it's going to be pretty accurate. So not only in terms of diagnostics, but I think in decision-making and care, obviously, there's going to be a big push.
Yes, sir.
We keep hearing that Obamacare is going to implode or explode, depending on who says it. But anyway, the issue I see is that we ended up with a whole bunch more people on insurance, having insurance. Therefore, the insurance companies got a lot more premiums, and the hospitals got paid for work they used to do and distributed across everybody else. Has Obamacare lowered this at all, or is this where some of your curve bending has happened?
So let's take the first part, by the way. Why is everybody saying Obamacare is going to explode?
Well, the concern is that we had significant premium increases last year and coming into this year, and in a whole variety of areas, the number of insurance companies offering coverage have been scaled back. So they say, oh, it's just going to implode. There's going to be a death spiral. No one's going to offer coverage. So first, on the premium part, I actually, on the way here, looked up the premiums in Houston went from the typical the one that's used as like the benchmark plan went from $260 to $290. So that's a 13% increase in 1 year. That's a pretty noticeable increase. But here's why on the beneficiary side, there's no such implosion. So that went up by $30 a month. The tax subsidy, the premium subsidy for someone earning $30,000 or $30,000 a year also went up by $30 a month. So the net increase for that person went up by exactly zero. So you can't really get the death spiral. Now, that's on the beneficiary side.
Right.
What about on the payer side? I do think there's some significant concern that the number of insurance companies playing for next year, and they have to decide right about now, it's coming up, the deadline's coming up, we may see problems there. But I think that's being driven at this point by a huge amount of uncertainty about, will we enforce the mandate? There's this litigation over these things called the cost-sharing rebates that are funneled through the insurance companies. Without that, it's an extra $7 billion in cost that the insurance companies would have to eat. So it's mostly uncertainty about
The risk pool.
about sort of how the whole thing works. S&P, which we can have differing views on the quality of the analysis, but S&P came out with a report basically last week saying there is no death spiral if we provided certainty to the insurance companies, because again, on the beneficiary side, it's not like you get the spiral that typically happens in insurance markets, because the higher premiums for most people are being offset by federal subsidies.
Okay, let's try to take a few more, please.
Russell Green with Rice University. Dr. Robbins, you started off your remarks mentioning that the system is not designed for patients. And that says to me that patients are unable to exert competitive pressure, as consumers to force the system to work for them. A lot of the proposals for fixing the system involve utilizing competitive pressure on the patient's side. I find it hard even to shop for insurance, let alone doctors, because the informational asymmetries are so large. How or could the proposals that suggest competitive pressure from patients work?
Well, I'll start. I think empowering people to take more control of their own health care, literacy to start with, but also to demand, there are all these campaigns about know your numbers and trying to improve patient awareness and have them get involved. I mean, oftentimes the example is used. People pay more attention to fixing their car than taking care and maintaining their own health. So awareness and accountability. But I also, there's this commercial on TV where the person sits on their couch, and I think it's lendingtree.com or something like that, where bankers' holograms just appear in your living room to give you the best rate on a loan. I envision either, I'm forgetting what the name of the restaurant thing, Open Table. So you can imagine Open Table where if communities, and look, Uber is pretty successful. They own no cars. Airbnb is pretty successful and own no hotel rooms. If there are ways to have, let's say, I need a cardiologist, and I go and you try to find it, right, on Open Table. And I see that Dr. Tapino is the best cardiologist in the city, but he can't see me for another 2 months. But I can see Dr. Smith tomorrow, and Dr. Giles will come and visit me at home today. So there are going to be technologies and things like that in my opinion, are going to help.
Let's try to take a couple more because we're short on time, please.
Bobby, question for you. You mentioned that universal coverage would be a solution. However, coverage doesn't equate to care.
Right.
The VA is a great example. You got lots of people covered, but they don't get care. The final part is the quality of providers. There are lots of young people that are very smart that have doctors for fathers, and they tell them, go to business school. Don't be doctors. So what you get is not great providers.
Okay, let's take a question right here. You want to comment on that?
No, I think you're spot on.
Okay, please, right here.
I couldn't disagree.
Dave Hansen from the MIT Enterprise Forum. Your comment about 80% of the costs are in the last year of life.
Yeah.
To me,
Well, I got the expert who can do factcheck.com on me here. He can tell you what it really
Not that
is.
high, but it's significant.
Yeah.
So let's just keep
Okay,
going.
let's 70, 80. Seems like that's where the money is. And if you're talking about the last year, the amount of that money is spent to prolong life another 2 months, 6 months, whatnot.
Right.
As opposed to spending money on vaccines for kids or some other drug to keep from getting hepatitis. it seems like, that's where the money is. Getting the cost of drugs down helps. Getting the cost of procedures down helps. But it seems like the real pot of money is there in that last year of life, but it's a third rail as far as the politics and the
So
emotional.
can we clarify this?
Panels.
Let's just get the facts out, because part of it's chronic conditions, which may not be related to age, and the others, what are the facts on this?
Last 6 months of life, actually, the share's been declining, and it's down to under 20%. I mean, it's still huge, but under 20% of the total cost of care is the last 6 months of life. But I think you're exactly right to focus on.
And what's the saying about two-thirds
So
is
wait,
chronic
20,
conditions?
20%? It's not 80%, it's
No.
actually 20%.
And then chronic conditions is the other 40?
I was being
Just to be clear, chronic conditions is the other 45?
It's chronic conditions is a lot.
yeah.
So here's where I think you're spot on, which is, and it comes back to the question about consumerism also. So if you look at Medicare beneficiaries and you rank them by their costs, the top 15% of Medicare beneficiaries account for 85% of total spending.
Yeah.
So healthcare costs are really concentrated, which is why the consumerism thing is great, but it's never going to move the needle that much. You've got to get at those really high-cost cases, and I would put forward to you that in those high-cost cases, we can do two things. We can try to prevent them in the first place, but the second thing is, once you're in that kind of situation, the most important thing is what the provider is recommending and what the provider is doing in those kinds of situations, because that's what drives the complex care.
An example, dialysis would be an example of that?
Well, dialysis is an extreme example, but even, I'll give you a personal example. My father passed away at Yale New Haven, and I'm a member of the National Academy of Medicine. So care on the ground, the doctor would say, we need to do X, and I'd call up 17 different doctors, get all these different pieces of advice. This was very expensive, end-of-life care. I'd go in and say, well, fancy such and such person said we should do this, and the doctor on the ground would say, yes, but he also has this other complication. You didn't take that into account. We can't do that. And we'd say, oh, okay. And we'd go with the doctor's recommendation. So what it leads to, I wind up with is, if you want to get at the really high costs in the system, you've got to be changing the provider's incentive, the information flow, coming back to clinical decision support, all of that. And the consumer helps, but I would put the provider stuff first and the consumer
We're going to take
second.
one last question right here.
That's fine. Well, first of all, Bobby, this is on a little more local level. Thank you for your leadership in reshaping TMC. U of A is getting a great leader. I'm sure the golf courses knowing you in the Tucson area were the swing vote for you to head west. But that being said, gentlemen, all these things that we've talked about on a more local level, how are they going to reshape and affect the Texas Medical Center, which is such an important component and economic driver for the Houston area and Texas?
Well, I think that Texas Medical Center is alive and well and is doing great things and will continue to do so. I think the bigger issue is going to be the community hospitals. I think a lot of this stuff is going to be, they're not going to be able to be competitive, and you're going to see them go the way that, the little town I grew up in, there were 3 drugstores and 2 hardware stores on Main Street, and now there are none of those because there's a super Walmart 10 miles away. So these smaller hospitals, I think, are going to be closing down and consolidating.
Is this because they just don't have the technology or the know-how?
I think they're not going to be competitive on a variety of things. Especially as you change to a value-based model.
Right.
I think they're just not going to be able to be competitive with the places like the Texas Medical Center in more advanced field. I will want to leave you with one footnote. If you thought this was a good discussion, come back for next semester, because it's only going to get worse. And here's where the big issue is going to be. And I won't put a number out there because I'll let Peter put the number on it. But, over the next 25 years, the care for dementia and long-term, as Ron has always pointed out, we're going to get cancer to a non-fatal disease. We're going to do better with cardiovascular disease, and then we're going to be left with people who are aging and dementia, and you mentioned skilled nursing facilities and those things. That's in the trillions. I'm not sure exactly how much, but trillions.
Yeah, this is one area where the drug innovation may, there are exciting developments, but we're not there yet. And, let's hope it does happen. But it also highlights another thing that we didn't talk about, and I'll just end on quickly,
Please.
which is we hear a lot about income inequality in the U.S. Life expectancy inequality is exploding. So if you're the people in this room, well-educated, the higher income people, life expectancy is going up really, really rapidly. If you're less educated and lower income, life expectancy in the leading country in the world is flat to down.
No.
Mortality rates are increasing and if you want to understand a lot of frustration with the political system and with our institutions, just look at the fact that mortality rates for a big part of middle America are going up, not down.
Right.
That shouldn't be happening, and it's related to, a lot of opiate abuse and what have you is related to that, and that's even before we get to, 2025 or 2030.
So let's just, the reason it's happened, also obesity, other conditions?
Obesity, smoking rates have collapsed at the top, but less so at the bottom, but that's not the major explanation. The major explanation seems to be something else, and I would put forward that it has to do with prolonged exposure to stress. That for many low and middle income people, their lives have gotten, whether relative to their expectations or in reality, it doesn't matter. In their mind,
Making ends meet.
Making ends meet is much harder than it was historically, and you're seeing that come out in suicide, you're seeing it come out in opiate abuse, and you're seeing it come out just in reduced health outcomes that then cause death in the world's leading economy. And we can do better.
Robbie Robbins, thank you for your service for all these years to this community, and good luck on what you're going to do next. We look forward to seeing you regularly, and thank you for your service to the Fed.
Thank you.
And on our board. And Peter Orszag, thank you for your service to our country, and thank you both for being here tonight. And thank you everyone.